big thank you for organizing this meeting. The first case is a patient of mine who had corneal opacities due to cornea guttata. Afterwards, also a cataract, reduced vision, and I was wondering if we do cataract surgery. So you see here the conventional spectral domain imaging of the central fovea. And after time, he said, well, the lines are not the same as they were, and you see here the subfoveal fluid accumulation and the RP elevation. So he had a central exudation. So we have a problem of the fovea here, another scan. One part is missing, and maybe AMD is only one part. The RP is more or less flat, and we were thinking it could be an AMD. So normally that was before, and after some months he had this central edema in the temporal side. Here you see in red and orange the fluid accumulation. But is it really only a central pathology, what you see here in the conventional scanning laser ophthalmoscopy? Maybe to the top left you see the lesion there, and AMD can make one mad because there are different possibilities. What is the real problem in that case then? The problem is that usually we have small pupils, and a dilatation is not always possible. And when you do a peripheral scanning of that lesion, you see this elevation in the temporal side of his eye. But that takes time to really acquire these images. And when we see then the cross-sectional images, you see the elevations of the RPE. Is that AMD? Who thinks yes? Hands up. Is it not? So we have peripheral lesions, but also in the fovea. A cataract, a decompensation of the cornea. This was then the view with the panoramic fundus imaging. On the right side, you see these lesions. Some are yellowish, some are reddish. And I give you some time just to appreciate these images, because we are now in a transition from small field to ultra-wide field. And we have to adapt to these new images. So this is the panoramic fundus photocolor imaging. On the left side, you see also these lesions. Some people can also have vitreal bleeding. So the fundus inspection is rather difficult in these cases. This is another person who came with sudden loss of vision, and also you see these peripheral lesions. Some are scarring, and you could also presume that could be also a tumor. This is one of the most misdiagnosed lesions. So this patient had a vitreous hemorrhage. Central was more or less clear, and this is a spectral domain imaging just to compare both possibilities what we have today. Again, scanning laser ophthalmoscopy with a regular OCTA device, and it's potentially possible also to miss these peripheral lesions, what you see in this case. He had also anticoagulation. The first one we decided to treat with anti-VEGF, and he responded quite very well. In this case, we just did a careful watching with OCT, but also here the scanning laser ophthalmoscope with a normal OCT device, and you see these elevations in the temporal side. OCTA does not help that much in this case, but you see in the periphery this elevation also of these vessels of the retina. Here another scan. It's a very rare disease. So this is scarring formation after bleeding, and you see to the left side a normal regular fovea. This is conventional imaging, and it took us really quite a lot of time to also acquire these images.
Peter?
Yes?
If you wouldn't have said it's a rare disease, I would consider peripheral choroidal neovascularization.
Yes.
PD, bleeding into the vitreous.
Look here. You're absolutely right. So some people have had enucleation because of that, and now that's the clue now. I show you a 3x3 scan with the new device, with the 400 swept source. So he had a little bit difficulties to fixate, that's why you have these lines. And now the miracle is coming. Now we are elongate to the periphery. Isn't that cool? And now you see this peripheral lesion in this patient. And this, I think it took us 10 seconds to acquire. And this volume rendering is really helpful because sometimes this lesion can look like a melanoma, but it's something else. I give you time to really appreciate these images because it's really something new, what we are not used in our daily practice. So we think it's a peripheral. What else? Exudative. And what do we see else? Hemorrhagic, sometimes, not always, sometimes. Retinopathy. Packer. Who has seen such cases? Hands up. They are not that frequent, but still very interesting. So in that case, we did only careful watching. In the first case, I did anti-VEGF, and the eye responded quite well. Sometimes they respond, sometimes they do not. We do not really know in which category they are. It could be, in the first session, we could think if it's AMD, but we are missing the typical signs of AMD in these cases. So the drusen are missing, the RPE is mostly flat, and I hope that the panel agrees to that diagnosis. They do. In the first case also, I did a cataract surgery. Afterwards, we did a DSAC and this anti-VEGF treatment. And the patient responded quite well and had a corrected VEA of 1.0, so 100%, and he was quite happy. So let's go further. The second case, cataract surgery is nothing special. It's a routine procedure until a patient is coming to you from doctor elsewhere, having only light perception as you see these membranes. I think beyond means holistic approach. So in this case, we have had a patient coming after routine surgery, and I was learning quite a lot of this patient. So when you have this situation, you can do also with the 400 kilohertz web source device quite fast an imaging of the anterior segment. It's not needed to make a diagnosis, but it's very useful for clinical purposes because we see then how the fluid in the anterior chamber is brought also to the open paracentesis or tunnel. And also in future, we will also have much more anterior segment imaging because this is his normal right eye. And then for comparison, we have the left eye. And here you see the anterior segment is filled with fibrin strands, cells. And between the pupil, you have this elevation of an accumulated fibrinous membrane, which is anteriorly positioned. This is then the 3D rendering. And you achieve that only with about 5 seconds. And these are new images, and we have just to learn how they look like. For patient education, it's very well suited. So I could manage that he is following our prescribed therapies. And you see here how the fibrin strands here, just at the tunnel, clear cornea tunnel, is attached to that opening there. And also to the paracentesis here. That's it. Thank you.